By having observed our patients over time, we've understood that not all patients are the same, and we've actually been able to show that literally in black and white. We can do analysis that show there are people who are destined to have more severe disease and some that are destined to respond quickly to our first medication we choose, and they do very, very well. What we need to do is do further research to help those people that don't do so well initially to be responders to treatment and lifestyle measures sooner. We've also used our data from our patients to define a patient-reported flare. We've used our data to define other reports. We've used our data to define thresholds of what we consider improvement and worsening in measures that the doctors use to when they examine their joints and determine how many are swollen and tender. And now we're embarking on research to target specific symptoms from patients like pain and fatigue, stiffness. We want to know what can we do to keep them working? What can we do to keep them participating in the social events and the work events that are very important to them? We know that we used a lot of our information and knowledge when we wrote the Canadian practice guidelines for rheumatoid arthritis in 2011. And then we went and compared how were patients doing before that and after that. And we saw a marked increase in the number of people who got into remission or whose disease got very well controlled. And we then went to look at why. And one of the key reasons was probably more effective use of medication like methotrexate. We used better doses sooner. We used subcutaneous dosing, and all of that made a real difference in terms of getting better outcomes. And as a result, we have not quite needed as many expensive biological therapies as we had needed earlier. But there is still room for improvement. There are about 30% of our patients that are not getting their disease controlled, and it would seem they're also not getting access to the treatments they should have earlier. And perhaps that's because they're using a lot of steroids, which kind of mask the disease and make it feel less severe than it really is. But when we take the steroids away, they flare. So we know that we want to be able to identify who's going to need a stronger treatment sooner, because we believe the sooner you give it, the more likely you're going to modify the disease in the long term. The other thing that happens is some people are still coming to care too late. We've tried to burst that bubble and have people get there by 3 months, but we haven't been able to do so yet.